Hello, and thank you for joining today's webinar. We will be getting started soon. Thank you for joining today's webinar. We will be getting started soon. Feel free to post in the chat where you're joining from today. Hello, and thank you for joining for today's webinar. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. No one in control of the content today have any relevant financial relationships with ineligible companies. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository in approximately 1 week. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so that the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We would like to thank our speaker for sharing their expertise with us today. Of note, thoughts and views expressed are that of the presenter and do not necessarily reflect that of Sigma. Our presenter today is Roya Hadiri Vijay. She is an assistant professor and researcher in the School of Nursing on the treaty lands and territory of the Mississauga of the Credit First Nation. As a first-generation settler and an uninvited guest on this land, Roya is grateful for the opportunity to live and work here. Her scholarship, underpinned by the Gadamerian hermeneutics, interpretive phenomenology, and mixed mythology, is focused on underserved populations and individuals who identify at the intersection of identities. In particular, her focus is to enhance and advance the health and social cares of 2SL LGBTQIA+ migrants, youths, and older adults. Roya, go ahead and take it away.
Thank you so much for a warm introduction. It is so wonderfully overwhelming to see all the places that every one of you have joined us. And thank you for the opportunity to engage in some conversation with you. I just like to first start with the disclosure of interest, and I'd acknowledge that uh, these are my views and not necessarily of my employer or any affiliated organizations, which includes York University, Rainbow Nursing Interest Group from RNAO, Durham chapter RNAO, or Lambda Pi at large chapter through Sigma. What I also like to do is acknowledge the land from which I join you. And as we're meeting in this virtual platform, we honor the Indigenous people of all the lands that we're on today. As settlers, we commit to reflect on our positions and privileges and on ways in which we have benefited from the settled colonial violence that has led to Indigenous peoples being dispossessed and displaced. This ongoing collective suffering and trauma requires our commitment to dismantle settled colonialism. Indigenous peoples have resided here since time immemorial and continue to thrive in this place that we call home. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. I join you today from Toronto, or Takaronto, which is still home to many Indigenous people from across your island. And as a first generation settler, I'm grateful to have the opportunity to work, live, grow, and have a family of my own in the communities that have grown in the treaty lands of the Mississaugas. I'd like to also invite you to share with us from which land you're joining us. And thank you. I see some of you have already started that. Thank you. Oh, my apologies. Just going between slides. So what I like to do next is do an acknowledgement. So rather than leaving this to the very end, I would like to extend my heartfelt thanks to the informants. And when I use the word informants in this research, it's because instead of using the word participants, I'm acknowledging that those participants were informants who shared their experiences with me. So I would like to start this presentation with really acknowledging them and thanking them for making an invaluable contribution to this research. I'd like to also share at the very beginning that the pseudonyms and the pronouns that are used in these presentations are the ones that were selected by the informants themselves. So it was not me as a researcher in position of power making up names or pronouns or so forth. But before we started any of the interviews, I asked them what pronouns and what pseudonyms would you prefer? And I explained to them what that means. And all those names and pronouns is reflective of that. In addition, I want to extend my gratitude to my PhD supervisor, Dr. Carol McDonald, and my committee members, Dr. Nancy Clark, Dr. Judith McDonald, and Dr. Anna Liv, for their continuous time and support. And also Dr. Lee, who was my external reviewer, for making tremendous recommendation and comments and helping me through this process. I would also like to acknowledge the funding I received from Centennial College, University of Victoria, and STTI Lambda Pi Large Chapter for their support. So the overview of this presentation is situating self first. And this is it's key and important because I use intersectionality with Gadamerian hermeneutics. It's important for us as researchers, as practitioners, to first situate ourselves. So I'll start first with situating myself, then the research question, the theoretical framing and methodology, the interpretations of interviews. In other words, some of you may be familiar with the word analysis. So in Gadamerian hermeneutics, we use the phrase of interpretation of interviews, and some of our transpired understanding from that. The presentation content, and before I start sharing, I wanted to acknowledge that this is not a positive space training. Oftentimes, we need several hours for positive space training, but at the end, if you like to email me, and I can share with you some resources that you can access if you like to know more. But I also want to share that some of the content in this presentation will include topics that some may find as offensive or traumatizing. And the reason for that could be because some of you may have had similar lived experiences with the informants. And some may also find experiences potentially disturbing, but these are the realities of what the LGBTQI migrants experience in our healthcare system. I would also like to ask for us to help to create an atmosphere of mutual respect. And as we leave comments in the chat box, be mindful that there could be others as participants who have some of these shared experiences, or those who may be watching the video later on. We just want to make sure that we create this respectful, sensitive environment for all of us. So starting with situating self, perhaps one might ask, why, as a first-generation settler, heterosexual, cisgender, and now a Canadian citizen, I have pursued this research? You may wonder. Almost 2 decades ago, at the end of my 4-year nursing degree in Canada, I learned that my friend was admitted to a psychiatric unit with suicidal ideation related to her non-heterosexual identity and compounded trauma. Unfortunately and sadly, initially, I pitied her for not being straight because that's what I had heard, being straight. At that time, my cultural understanding resulted in my limited knowledge, and I believed that LGBTQI plus people had a mental or hormonal imbalance that needed some form of fixing. My nursing education did not contradict this biased understanding since LGBTQI plus people were only referred to in the context of sexually transmitted infections and mental health illnesses. During her stay at the psychiatric unit, she encountered nurses who were neither aware of her complex experiences of persecution due to her religion, nor the internal conflict with identifying as an immigrant, lesbian, Baha'i. The following comment was made to her by physicians and nurses in psychiatric unit upon discharge. So you're gay. What's a big deal? For her, being a lesbian was a big deal. And given her culture, religion, and relocation to Canada, one that led to suicidal ideation. Subsequently, while still experiencing suicidal ideations, she was discharged without a client-centered plan of care. For this reason, and several other experiences in my nursing career, I became aware that experiences of LGBTQI plus migrants may have not been clearly addressed in nursing. In situating myself further, I had some shared experiences with some of the participants that allowed us to delve deeper in their interviews, and these were having no human rights as a Baha'i in Iran, escaped Iran with human smugglers and became a non-status illegal refugee in a transition country, watching my father shot in front of my eyes, and were a new immigrant in which I experienced bullying and racism. Beyond this nostalgic experience and situating myself, let's look to see what do we know from the literature. Briefly drawing from the literature over the past several decades, some nurses with social and mental health care providers in collaboration with migrants, LGBTQI plus people, or those at the intersection of identities have strived in allyship and advocacy in advancing safe and affirming spaces for LGBTQI plus migrants. As we can see, the work of my committee members, Dr. Lee, Dr. Liu, are a testament to this work. Despite the work of nurses and other colleagues in education, practice, and policy in a Canadian context, there has been evidences of heterosis normativity and non-affirming care in healthcare practices with marginalized people such as LGBTQI plus migrants. Most importantly, LGBTQI plus people are a subset of migrants who have had another layer of challenges in navigating healthcare services that require trauma and violence-informed care. For this reason, upon its inception, the purpose of my research was understanding the experience of experiences of LGBTQI plus migrants' encounters with nurses. However, in addition to their experiences with nurses, the informants shared their experiences with other health and social care professionals in Canada. And as you know, as a gatekeeper in position of power, as a researcher, I could not dismiss these shared experiences. Situating the experiences of informants was through the utility of Gadamerian hermeneutics with intersectionality as an analytical lens. Drawing from the work of Collins and Crenshaw, intersectionality is not only about identities. Rather, the core argument in intersectionality is that dominant power and hierarchies have socially excluded individuals based on interlocking oppressed identities and orientations that are not the same for all. As I mentioned, for the remaining of these presentations, I will use a Gadamerian and hermeneutics language and use informants when referring to participants. So 18 semi-structured individual interviews were conducted with two groups. One group was 16 LGBTQI plus migrants who were recipients of nursing care, and 5 nurses or nursing students who experienced, observed, heard, or witnessed the provision of care to LGBTQI migrants. What was interesting from these 5 nurses, as you can see here, 3 also identified as LGBTQI plus migrants. I have this briefly here for you, and I just want to draw your attention to the age group. And we see that the oldest of these informants were in their late 40s, but we can see, and I share some of examples, it shows the fear of aging and dependency for many LGBTQI people is magnified for those who were also racialized and migrants because they see some of this racism already and within their care that received at a younger age. What I also wanted to point out is that although two-spirit individuals were included in all research documents, none of the participants self-identified as two-spirited, and for this reason, the initialism was changed from 2S LGBTQIA plus to LGBTQIA plus as well. So gaining understanding occurred through interviews, and not all of the questions were asked, but I listened thoroughly to how various factors shape the experience of LGBTQI migrants with nurses and healthcare professionals. I conversed with the interviews in relation to the topic and then the specific experiences by reading and rereading the transcripts iteratively and searching for similarities, differences, what stood out, what was provoking, even what called current understanding into question. I opened myself up and listened to what was being said and unsaid, even confronting viewpoints which may have been hard to hear and observe. I use intersectionality to ground hermeneutics and understanding the experience of LGBTQI plus migrants with nurses and other healthcare professionals by being critically attentive to intersections of broader systemic process of exclusion and harm, as well as how systems of power may operate to mitigate oppression and how they can be potentially illuminating during in-depth interviews and interpretations. What I have here for you, and this could be another conversation, maybe another sharing more, but what you see this image, it was actually the image I painted during my interview and analysis as I was delving deeper and deeper and trying to have a better understanding. And if you'd like to read a little bit more about this, you can find my dissertation. And just to let you know, what you see here that looks like a tree, it's actually the placenta of my daughter that was born during that time, and I stamped it in this and there's so much meaning, so much more meaning to that. But it's beyond our time for today. So if you have any questions, please feel free to connect with me. What I'd like to share with you very briefly as well was that the interpretation or analysis that occurred at not at one point in time. It started during interviews, it continued during transcription, and again further in rereadings and discussions with my committee. And rather than reading the abstract or naming the manuscripts I prepare for publications, and they're there, I invite you for the remaining of our time to join in my journey as I provide a summary of some of those interpretations. Two overarching areas of intersecting experiences were identified. One of them was supportive experiences in encounters with nurses. On the other hand, we had interwoven experiences of challenges. So starting first with, on one hand, informants shared experiences of affirming practices in which nurses understood their intersecting experiences of SOGI. So what that stands for is sexual orientation, gender identity, and expression, and also what's missing is sex characteristics. So the nurses who understood those intersections of, these experiences with migration status, with religion, ethnicity, race, and mental health, and that all led for them to feel that there's affirming care that for nurses, that they understood all those things come together. And there's a few examples that I share with you in the next slide. Encounters with supportive nurses and healthcare professionals included nurses who listened and asked appropriate questions to, for example, writing letters for refugee claimants' court hearings, and nurses who followed up after LGBTQI migrants' appointments, surgeries, or discharges. Joanna shared that nurse's compassionate and kind follow-up phone calls after being discharged from a mental health facility supported her. She shares with us, "It helped me. It took out a lot of my pain, feelings, and fears because every week someone was there listening to me. So I think it was great." Joanna experienced the nurses' not judgmental and supportive presence. Similar to Joanna, other informants found words of encouragement from nurses and healthcare professionals helpful. And these made them feel accepted and not marginalized in the healthcare systems. Participants underscored the support of nurses who provided detailed step-by-step information about procedures to assist with language barrier. The step-by-step guidance gave LGBTQI+ migrants a sense of assurance and comfort. They also felt comfortable and cared for when nurses had technical and therapeutic communication skills. Nurses demonstrate understanding contextual intersecting experiences of LGBTQI migrants where they use inclusive language and recognize traumatic migration trajectories. As an example of nurses having both the technical experience and therapeutic experience, one of the informants shared, and this is about the nurse, not only he, the emergency department nurse, is skilled in terms of like taking IVs, doing the test, but then he was correcting his other colleagues. For example, X-ray tech came over and used he and him, and then he corrected him that it is she. So he was taking care of other people, like they would make sure that I'm feeling comfortable there. And we see how those simple acts were so meaningful for the informants. Now, on the other hand, interwoven experiences of challenges were their unwanted visibility in the healthcare system. Hearing their dead name, being misgendered, experiences of structural, social, and cultural stigma, the intrusive, heterosis-normative questions that were traumatic and limited affirming spaces for their intersecting identities. One of the barriers to affirming care was when nurses made cynical comments. The following two examples elucidate these experiences. Joanna, a racialized trans migrant with a student visa. So I'm just going to pause here for a second for you to understand the complexity of this informant's experience. Somebody who, again, this is the language they use. I'm always very careful when I use the word racialized, but that's how they identified. So they identified as being racialized, trans, migrant with a student visa. So we can see the precarious state of them being here. They were experiencing suicidal ideation and they were brought to a mental health facility by the police. According to Joanna, this facility was in an urban city with the heart of LGBTQI plus neighborhood and had visible ally flags. So Joanna thought that this would be a safe place. And she tried to verbalize her fear of police and deportation to the mental health unit nurse. And this is what transpired. She asserts, the nurse answered me cynically, yeah, everyone is here because the police bring them. What? Please don't tell me this. God, when she answered me that way, I was like, okay, I'm going to just shut up and take the pill. Joanna was shocked that the nurse dismissed her traumatic experience of being brought to the mental health facility by the police. Some nurses did not engage in serious solidarity to understand their patients' contextualized fear of deportation and police has resulted from previous trauma perpetuated by dominant systems of power. Another informant, Ali, shared his traumatic experience with nurses in Canada. Ali identified as a racialized trans refugee who arrived in Canada less than a year ago. He only used public transit and avoided taxis due to financial barriers. He was not aware of needing a ride after top surgery. And unfortunately, he encountered unprofessional nursing behavior in the post anesthetic care unit or PACU. The nurse was punching my chest to wake me up, and I had surgery on my chest. She constantly used the wrong pronoun, and when we didn't know about using taxi, she said, nobody doesn't know how to order a taxi. The nurses did not understand the intersecting experience of a new migrant who also identified as trans and refugee. Ali told me that he was not familiar with navigating the healthcare system in Canada and was not able to defend himself because his verbal communication was restricted because of anesthetics. Consequently, Ali felt forcibly silenced by not being able to speak up for himself when the nurse misgendered him and punched him in his chest right after top surgery. He was shocked that PACU nurses after top surgery had not played their roles affirmingly. In fact, Ali thought nurses working in this facility would be allies because of the rainbow signage and the surgeries conducted for trans people. For this notion, informants found ally theater to be a problem. Another migrant, another participant and informant who identified as migrant, non-binary, and trans tell us that ally theater is a problem. Don't put up a rainbow flag if you're not going to actually support every member of the LGBTQI plus community. It does require that you put in some work and make spaces safe, and I like to add safer and affirming. Moving forward, there were 3 challenges for informants who started their gender transition in Canada. First, their name and gender on legal documents did not match their transition identity. Second, they may not have been able to change their name and gender on documents as a result of their country of birth laws or Canadian provincial laws. And I'm just going to pause here and give you an example. For example, in some countries, if the person wants to travel back to their country of birth, then and they want their gender and name changed to be all changed, They have to have completed all surgery, top, bottom, and so forth. Otherwise, they're not able to identify as non-binary or have not done the surgery and so forth. In some provinces and some states, as you may see from all over, there are different policies. What also was another challenge was that they have access healthcare services in which they were vulnerable to being misgendered and dead named. Elham, a trans migrant healthcare professional, shared her multiple and complex intersecting experiences of what she called a migration within a migration. The difference between these laws for LGBTQI people delayed or even made changes to legal documents extremely challenging. Meanwhile, informants still encountered nurses and other healthcare professionals when seeking help with their routine healthcare concerns. And for those who started their gender transition process in Canada, it meant additional visits and potential risks for being dead named or misgendered. Another informant, Amanda, shared that hetero-cis-normative questions are intrusive and intertwined with nurses and healthcare professionals' binarized normative understanding of sexual orientation, gender identity and expression, and sex characteristics. When Amanda disclosed that she could not be pregnant because she's in a relationship with a woman, this was her experience. Cruel, sarcastic, alarmed expressions that the doctor and the nurse passed between themselves. She went on to tell me they drew a conclusion that I'm in a heterosexual relationship by saying, "Is your husband here? How many kids do you have?" Meaning, you already have a husband after all, you're Black. Black people get married all of the time. They knew from my accent that I'm African. You get discouraged with questions like that. Now you don't know if you're being ashamed again for being a lesbian or for being Black. I asked informants what supportive care can nurses and other social and healthcare professionals provide for LGBTQI plus migrants. And I will share a summary of implications in two areas of policy and education. The reason informants asked us to lobby for mental health support was due to past and recurrent experiences of discrimination and stigma, challenges in accessing affirming migrant LGBTQI+ mental health care professionals, and the financial cost of these services. Many informants suggested that intentional inclusion of migrant LGBTQI+ as health and social care providers may mitigate hetero-cis-normative views and provide comfort to those who are racialized LGBTQI migrants accessing healthcare care services. One informant stated, "As a person of color, as an LGBTQI+ person, when you walk into somewhere, you make a mental note of how many colored people are in a room. Number one thing that makes you become comfortable is because it is diverse. Another one is knowing that there are actual LGBTQI folk here who have lived experiences as migrants." In this study, it was evident that LGBTQI+ migrant nurses and non-migrant nurses received minimal guidance on their nursing education to inform their practice when caring for LGBTQI migrants. In regards to education, in peeling the layers, informant asked that experiences not to be taught in silos, because oftentimes, I know a lot of times, we teach, a week on experience of migrants, some weeks on refugees, another maybe, if we're really progressive, on towards LGBTQI+ health, but not in all the silo, but not the intersection of those experiences and what are those unique experiences. Mariam, one of the participants, adds the importance of trauma and violence-informed education and states, on top of 2S LGBTQI plus education, to add a layer of LGBTQI plus newcomer. And then with the newcomers, I would highly recommend having a differentiation between newcomer immigrants versus refugees from the LGBTQI plus community. Training is definitely needed. So then they would be able to know how to welcome, how to treat, how to serve, and what could be extra layers of vulnerabilities that would arrive on the table. All of the informants noted that LGBTQI plus migrants are in contact with nurses and other health and social care professionals beyond community centers, and underscored that these encounters may occur at any level of health and social care systems. For this reason, all points of access need to be affirming for LGBTQI plus migrants. I would be happy to delve a little bit further, but some areas for future research, as we're thinking about that as well, is that, and I'm just going to share this as well. One of the first parts that I noticed, a lot of participants and informants in my research were also identifying as current or past LGBTQI migrant students in college and universities. And they shared that how there was limited access, there limited support that addressed their unique needs when they were in schools that would impact their success. So one of the studies that actually we're working on with my team is sense of belonging and well-being of LGBTQI plus migrant students in secondary institutions in Canada. One other thing that was brought forward, and it was a gap again from informants, was experience of those who identify being racialized, Muslim, and trans women as healthcare providers donning hijab. And the reason for that, and I alluded to this in some of my other writing, was that for those, so one of the participants who wanted to use the services in the hospital, they were concerned and they were worried that, you know, they don hijab, they're a healthcare provider, but in the change room, they're worried to even say hello to their colleagues because they're worried that other people, other women in the change room would feel uncomfortable. And how do we actually create those safe and affirming spaces for our healthcare professionals at the intersection of these identities? One of the points here as well I have is around Iranian care professionals' perception of the needs of 2S LGBTQI migrants people. And the reason for that, as I've been engaged more and more in this work, I noticed through my conversation with some of my colleagues who are healthcare professionals and nurses who have this identity of being Iranian and Canadian or Iranian, and I have some connections with colleagues in US and other parts where there's still a lot of misunderstanding around what 2S LGBTQI plus migrant healthcare needs are. And one of the other areas that I suggest for us to consider is using epistemic injustice as a lens to have a better understanding. I do have 2 slides because I've started to do some work around that, and then hopefully we get some more time to have, if there's any questions that I can answer. So starting with what about epistemic injustice? What we notice and what I shared with you that both stigma and discrimination, which define as a lack of knowledge of and a sense of discomfort in providing care for LGBTQI migrants, was found to manifest in the study. And we find that there was some of these limited understanding of the experiences of LGBTQI migrants in this context. And the LGBTQI migrants continue to have troubling care experiences with nurses. So who is Miranda Fricker? Miranda Fricker has developed the concept of epistemic injustice in her work by drawing on feminist philosophy and social epistemology. And epistemic injustice refers to unfair treatment of person by judging them as a not knower in a communicative and testimonial situation. For example, in a few situations, we notice these experiences where nurses says, "Oh, they're here, they're in Canada now. It's safe here. Or what I shared with you earlier on. So you're LGBTQI plus, like what's a big deal? These dismissive statements reflect an epistemic situation in which the hearer is negating what was heard, i.e., that the speaker's intersecting identities of LGBTQI plus and new migration has directly led to their suicide ideation. The concept of epistemic injustice helps to frame this situation as one where the care provider is not doing justice to the need of LGBTQI plus migrants. And what I'd like us to think about, and as we conclude um, this time together, is that think about the phrase window to examine discrimination. And here I add the misunderstanding. And my intent here is to illustrate that the epistemic notion of a phenomena could be interpreted, understood, or even misunderstood as a result of multiple perspectives charged by positionality of knower and hearer. For example, a window becomes a chattel where it is many things to many individuals by the very nature of the word window, being open to multiple interpretations. These multiple interpretations without given context may lead to misunderstanding. Therefore, understanding of a window, its location, shape, and purpose is morphed by the interpreter's contextualization in line with a communal understanding of the relevance and purpose of it. Individuals bring their context and time and positionality in their interpretations of dialogue. So in this case, what we heard from all these experiences, is that what constitutes an epistemic notion of their experiences is taken up by the hearer. This concept of epistemic injustice is not a new concept. It has been taken up in healthcare research to explain how injustices and misunderstandings occur between healthcare providers and clients. And what I'd like to share is that what we see that migrant LGBTQI plus patients experience these epistemic injustice when they were in a non-therapeutic relationship with nurses and other healthcare professionals. And this was a common experiences that we see as well. I hope that by sharing these experiences, I have been able to share a glimpse of these what was shared with me. Thank you so much for all being here. And I want to again thank my informants. And I put some of these references here for you, the quotes that you like. You can always connect with me. One thing that informants asked me to do said, please don't let this be another research that stays in publication. Share it in different with different avenues, with different nurses, healthcare professionals, future nurses, current nurses. So even if one person make a change in their practice, this is going to be good. So at this time, I want to again thank you all for being here with me. And if there's any questions, I'll be happy to answer those.
Thank you so much, Roya. As she mentioned, if there are any questions, you can feel free to use the Q&A feature, and then we can use that to address any questions that you have. Let's see. I know someone was asking about your contact information, if you were on LinkedIn or you had a way that they could reach out to you.
Okay, I'm on LinkedIn. So if you look me up on LinkedIn, you'll be able to find me. And this is also my email, rvj@yourq.ca. So yes, please feel free
Thank
to,
you.
yes, absolutely. And if there's any questions that come up after, I'll be happy to, however I can help. Absolutely.
So one person has a question about the term racialized and would like a little more explanation on what that term means.
Thank you for that question. I think that's an excellent question. We know that there's some discourse and dialogue around the notion that the word racialize, it it actually can is not, it might not be a positive term for some. For example, I would not want to be called, and I know some of my other colleagues who do not want to use the term or be identified or be called racialized, but using the notion of um, Dr. Spivak, where they talk about we can strategically essentialize a term so we can ask or we can lobby and advocate for services. So we always have to be mindful. So if somebody who identifies racialized being as a result of their location, their contextual locations, we need to be mindful of how we use that terminology. And for those of us in position of power, we don't use it in a negative format or not to further stigmatize the community and the people who are engaged in research with us. To be very, one of the things I'm hoping that I shared with you, and not maybe too much detail here, being mindful of our language and our wording as well when we're working with our participants. So that was an excellent question.
All right, thank you for that. And how do you think that we could include these topics in undergraduate curriculum?
Great question. I think we got to start from the very beginning, um, starting with just rudimentary language, terminology, pronouns for our students. Um, there is either we have positive space training or we have Soju Nursing, which is an open access source that some of my colleagues have created, right? That we start those dialogues. We show this in every content when we talk about even health assessment, right? How do we create those safe language and affirming language? When we think about the care that's provided in our case studies, are they always the same people? Is it always Mr. and Mrs. Smith? Or are we actually including somebody as a family who are migrants, who maybe they have a son who's going through transition, or a family who are the bisexual family who are the refugees, or those who came for other reasons. People migrate not only as refugees. Somebody, they may have migrated, as I shared with the example earlier, as a result of religious persecution, war, and other reason, but they also identify, they have these other intersecting identities. So starting them with like really looking at our material, our courses, our case studies that we have our students, is it always the same? And are they always in silos, or could we include them? And I understand it's hard at maybe not the first semester might just be using inclusive language and then build on it through each semester, each course, thread it throughout, in our health assessments, in our theory courses, and not just under silo. I think that was one of the things that participants shared as well, threading these content through your undergrad. And also consider doing that. Like if there's in-service or sessions that you can have for your healthcare professionals at the community center or within the hospital, is there space and I know I'm speaking from a position of privilege from where I'm situated and where I join you, from some of the changes that we are hearing or hear occurring globally. Um, this may not be possible, and I acknowledge that. But really, what is our role as nurses, and how we can actually create those safe and affirming spaces for a member of community who have experienced this oppression as well. Thank you for that question. Any other questions?
Yes. So, what are the next steps for this work for you? Do you plan to take additional steps to disseminate?
Um, Thank you for that question. So yeah, so as form of dissemination, beyond publications, I try to make some of my publications open access so anybody can use it. Oftentimes we are in academics, but beyond that, I'm very thankful for the team at Sigma. I know our colleagues here at Rainbow Nursing Interest Group and RNAO Durham chapter, they shared this call with all our members to really share this beyond just academia. I'm also working with some different organizations within Canada where I'm sharing these findings and looking to see how we can look through our policy. So we are working on how we can, again, include this more and more, and not for it to just be something that we don't talk about. We need to talk about this. We need to share this. I'll be happy to, if you feel it would be beneficial for your courses, for me to come in and do maybe a short presentation for them to hear more. I'll be happy to do that. Again, I felt so privileged for the participants sharing these experiences with me. And they said, Roya, don't let this be, again, something that is sitting on a shelf. Share this more so we can see, when hopefully students or nurses, they hear about this, they can actually acknowledge some of those discriminatory language, or perhaps avoid as well those languages. What was interesting was, it wasn't presented in this research, but some of the refugee LGBTQI migrants shared with me that they're like, it was interesting when nurses told us, "Oh, you don't look like a refugee." And they shared with me, what does that even mean? What is a refugee supposed to look like? And they're like, they meant it they're trying to be positive, saying that, oh, you don't look like a refugee, but is there like a category that we need to fit into as a refugee? Or they heard like, oh, your English is pretty good. Like, yes, I was educated in English school and so forth. So these notion and our own biases of what to a LGBTQI migrant person might look like or be like, or making assumptions of what their needs are, also for us to think about, as well as we are looking into changing our policy or practice, and really standing up, having, instead of being a bystander, um, where we hear those comments made when misgendering, where we constantly hear those heteronormative language or comments, really speaking up. And it can be, I have to say that it can be exhausting. So it shouldn't just fall on the person who identifies a member of the community, or taking on tokenism, where they're always leaned on to share their expertise or their experiences or educating, but really as critical allies, we need to step in as well, and not just putting it on the shoulder of our one, say, LGBTQI migrant faculty, or the one LGBTQ nurse that we have on the floor, to just ask them all the questions. I think we need to also encourage that within our education, within our practice, with our learning plans. But yeah, disseminating it in every way that we can, and as much as possible. Thank you for the question.
All right, and we do have another question here. So can you explain why Gadamerian hermeneutics was important to this study as opposed to general interpretive phenomenology methods?
Thank you. Thank you for that question. Yes. So Gadamer, and it's very interesting, and we can get a whole conversation around Gadamer and why I did not use Heidegger versus Gadamer's work. But one of the things that stood out for me in Gadamerian hermeneutics is the the notion of, and if you read Gadamer's later work before he passed away, was the importance of us really being able to look what is questionable as a researcher. And that says a lot, right? For us to being open to understand our own context, time, and thinking about the past, present, and the future of those contextual experiences. And that really stood out for me when I was reading the work of Gadamer, Gadamerian hermeneutics versus just the lived experience. What also was helpful with Gadamer hermeneutics was a notion that, I cannot separate myself from the research that we do. And some of those shared experiences that I had with the participants help us to have a deeper understanding of their situatedness. For example, when participants, shared their experience of being in transition country before coming here, and having that shared experience and engaging the conversation became just a deeper dialogue, and knowing that we're not blank slate. But like one of the reasons that I used Gadamerian hermeneutics, and also Gadamer asks us to really think about is not just about philosophy and philosophizing. To my understanding, again, my humble understanding of Gadamer's work was that really, what does it mean for practice? How are we going to engage in changes in practice to inform our work? Not just reading, but actually applying those understanding into our practice. And again, looking at context, time, past, present, and future. Thank you for that question.
Thank you for that. Um, so one other question here, is there a higher burden of illness among sexual and gender diverse migrants compared to the native SGD population? Do you know?
Uh, I'm not sure I understand the question.
Um,
Perhaps you'd like to email me and I can. Uh,
yes.
sure.
I'll make sure I'm gonna put, Roya, I'm gonna put your email again in the chat here. For those that may have specific questions to answer. Anything else? Is there any closing words that you wanted to share as we move on today?
Thank you so much. Thank you all for making the time to being here on a December as you're preparing for the holidays. But I ask you to be mindful of our position, our privilege, and our Harvard biases that we hold within us, and looking for opportunities to engage meaningfully in a critical way. If you claim to be allies, be a critical ally and support those who are in our care during the holidays. I know you're all doing such a great job as nurses. You're here, you're engaging in this work, and I want to appreciate all of the work that you're doing. And thank you again for the opportunity. Thank you so much, Megan and Linda, for making this happen through Sigma, and my colleagues as Dora Maraneo and Arnik to share this call. And also our chapter, our Lambda Pi at Large chapter for making this happen. Thank you so much, everyone.
And thank you, Roya. We appreciate you taking the time to share all of this information today. And Sigma is grateful that you have taken the time to share with this audience. And we look forward to hearing more from you in the future as you continue to disseminate the things related to your research. We hope everyone enjoyed this webinar. We have updated our process, so webinar attendees can now access our learning management system to complete the evaluation and obtain your certificate right after the webinar concludes. Please note that you will not be able to click on the screen, and we have put the link there in the chat, so you can definitely click that. If you're unable to click the link in the chat, we will be emailing you the evaluation through that way you can access the link there, so you can always look for that email once that's sent out and access the evaluation through Sigma's learning management system by searching the title of the webinar. In addition, you will get that email within about a week of the webinar so that you can access that. And so I hope you have a wonderful day, and thank you for joining us.